First of all, I would like to thank all the attendees and our guest speaker, Dr. Goutham, for accepting our invitation to speak about the endovascular management of ischemic stroke. I welcome you, sir, Dr. Goutham.
Thank you, sir.
I also welcome Dr. Anand Sanmugraj, our consultant neurosurgeon from the Tandem Medical College, and Dr. T.C. Ramakrishnan, consultant neurologist from KG Hospital, and Dr. Arul Ramraj, who is a consultant radiologist from Sri Ramakrishna Multispecialty Hospital, for being accepting as a panelist. I thank our dynamic secretary, Dr. Rajesh Babu, for making it possible each and every time. And I thank the pharma company for making it possible. I welcome one and all for this CME. Hope it's a very important, being it's a stroke day. We'll start the program without any delay. Thank you very much. I also welcome on behalf of Dr. L. Murugan, our president, who is unable to attend today, but he will be hearing our speech from his workplace. Thank you. Thank you very much.
I welcome you, all of you, for this today's TANS CME, which is to commemorate the World Stroke Day. See, actually, for all the months, every month, there are important health days are coming, which is related to the general health or for the neuro also. For the neuro topics, we are conducting these CMEs regularly. And last month, we had the Alzheimer's Day. And next month, we are going to have the Epilepsy Day. National Epilepsy Day is going to come next month. So like that. And also along with that, we are planning to conduct one more CME related to the interesting topics, which will be helpful for the students, exam going students, and also for the PGs. That is the main aim of conducting. Already our Neurological Society of India, NSI, is conducting periodically. Every week they are conducting 2 meetings. They are conducting actually 8 meetings. They are conducting per month actually. We are planning to conduct at least 2 meetings. That's what we are doing it. So today we are going to have the nice speakers. And the World Stroke Day is a very, very important event. Because even now also, if anyone suddenly develops any of the transient ischemic attack or sudden weakness of the limbs, even our parents or relatives, elders, suddenly developing, immediately what to do? We are in a dilemma and we are not able to take decisions like that. So we should have a nice protocol and we should create a protocol and follow the protocols so that it will be very much useful for all the practitioners, whether it is for the general practitioners and also for our specialists also, it will be a guideline. So that we will be able to, our speakers today may be giving a very elaborate discussion today. And regarding the activities of the TANS, we are already crossed the last leg. We are coming to the last 6 months of the TANS. And by this March end, we will be handing over to the new office bearers. That is the current status. And from April onwards, the new office bearers will be taking over from the Coimbatore TANS conference. And already regarding the accounting system, the accounts are going to be completed as early as possible. Within first week of November, we will be completing it. And then regarding the society's registration, we need to do it. That we have to complete the process. All those things are there. Our dynamic finance secretary, Dr. Kodiswaran, is looking after everything. And our office bearers are continuously going on, vigilantly doing the work. So I welcome each and every one of you for the program. Goutham, who is going to give a talk on reperfusion for acute ischemic stroke. He is the consultant endovascular neurosurgeon, Vinayaka Mission Super Speciality Hospital, Salem. He has completed his MBBS from Ramachandra University and MS also from Ramachandra and MCH from the Madras Medical College. And he has won his fellowship in interventional neurology and stroke, Max Super Speciality Hospital, New Delhi. The career is former consultant interventional neurology and stroke, Max Super Speciality, Saket, Delhi. Junior consultant at the Tamilnadu Government Multi-Speciality Hospital, Omandurar, Chennai. Assistant Professor Neurosurgery at Stanley Medical College, Chennai. Worked as non-registrar at the Department of Neurosurgery at Amrita Institute of Medical Sciences. Workshops and publications. Took part in more than 10 workshops pertaining to neurointervention, spine surgeries, etc. Paper published in Journal of Neurotrauma, the Asian Journal of Neurosurgery. Current position, consultant endovascular neurosurgeon, Vinayaka Mission Super Speciality Hospital. Area of specialization is the vascular neurosurgery. Dr.Arul Ramraj from MBBS from Stanley Medical College, DMRD from Madurai Medical College, and DNB from Apollo Main Hospital, Chennai. MCH Neurosurgery from Madras Medical College. The Assistant Professor of Neurosurgery, Tamilnadu Government Multi-Speciality Hospital, Omandurar from 2015 to 2019. Associate Professor of Neurosurgery from 2019 till date, Coimbatore Medical College, Coimbatore. So I request consultant neurosurgeon, Hindustan Hospital, Coimbatore. Areas of interest: cerebrovascular, endovascular, and skull-based neurosurgery, and neuroendoscopic surgery, and spine surgery. Now I invite Dr. Goutham, SP, to give a talk on reperfusion for the acute ischemic stroke. Welcome you, Goutham, sir.
Thank you, sir. So you're able to view my screen?
Yes, sir.
Yes, sir. So good evening, respected teachers and friends. At the outset, I would like to thank the TANS Tamil Nadu Association of Neurological Surgeons for giving me this opportunity to speak on reperfusion for acute ischemic stroke. So if you see, the principles of acute ischemic stroke care are to achieve timely recanalization of the occluded artery and reperfusion of the ischemic tissue. And we have to optimize the collateral flow in order to avoid secondary brain injury. So what do you mean by recanalization and what is reperfusion? Recanalization is defined by the degree of reopening of the occluded artery, and reperfusion is measured by the degree of flow reaching the previously hypoperfused brain region. So opening the occluded artery works because in most cases, when occlusion occurs, an area of brain tissue becomes hypoperfused, but it is initially not infarcted. That is what we call it as the ischemic penumbra. So defining the ischemic penumbra. So what happens when an acute ischemic stroke happens? So 3 zones of injury can be identified. The first zone is the ischemic core zone. So in the core, the tissue is irreversibly injured. Even if you re-establish the flow, we are not going to make the tissue come back alive. So the tissue there is dead. Next, you have the ischemic penumbra. So the tissue there is ischemic, but still it's viable cerebral tissue. So that ischemic penumbra is the main target of reperfusion therapy. And then you have the zone of benign ischemia, which surrounds the ischemic penumbra. That is the zone of benign oligemia. So what does that means? That is an area with a milder reduction in tissue perfusion that does not actually place the tissue at risk there. So the 4 P's of acute stroke imaging, if you see, is parenchyma, pipes, perfusion, and penumbra. So in this image, you can see that it is the perfusion study. It can predict actually how much of tissue will go in for infarction if it is not reperfused. For example, the area in red where the Tmax is more than 16 seconds and the relative cerebral blood flow is less than 0.2. So if this only the area which is shown in the red will be reperfused, will be infarcted if this vessel is opened in 90 minutes. So this area increases, the one you see in orange color. So to 90 to 180 minutes, this area increases if the reperfusion time is delayed. So when the Tmax is greater than 9.5 seconds, you can see that how much the tissue gets infarcted. So evidence-based strategies to achieve reperfusion. So how do we open up the occluded vessel? So there are two main strategies. One is IV thrombolysis with recombinant tissue plasminogen activator, which is RTPA, or you can use Tenecteplase. And other method is mechanical thrombectomy with a retrievable stent and a aspiration technique for large vessel occlusion. So if you see thrombolysis with Alteplase, so the IV thrombolysis, the full dose is usually 0.9 mg per kg, and it is administered. The first 10% is given as a bolus over 1 minute, and the remaining 90% is given over 60 minutes by continuous infusion. Other drug is Tenecteplase. So Tenecteplase is a bioengineered variant of RTPA. It has a longer half-life and it has a greater fibrin specificity. So Tenecteplase has increased resistance against tissue plasminogen inhibitor 1 than RTPA. So the advantages of Tenecteplase is it can be given as a single IV bolus, and you have the NORTEST study, Norwegian Tenecteplase stroke trial, which tested the efficacy of Tenecteplase in acute ischemic stroke. So the dose is usually, it can be given up to 0.4 mg per kg, but the safe dose is around 0.25 mg per kg. So if in IV thrombolysis, if IV RTPA is infused within 3 hours of symptom onset, it increases the chances of functional independence at 3 months by 1/3. So the benefit is time dependent and much stronger when the drug is administered within the first 90 minutes after symptom onset. As you can see, the number needed to treat is NNT is 3.6 within first 90 minutes, and the number needed to treat increases to 4.3 when it is between 91 to 180 minutes, and it is almost triples when it is between 3 to 4.5 hours administered IV thrombolysis with Alteplase. So as you can see that the Alteplase effects are time dependent. So you can see the odds ratio is around 2.55 when given in the first 90 minutes. So the number needed to treat is only 4 to 5 to achieve an OR of 2.55. So that when it reaches 180 minutes, so the OR comes to 1.64 and then NNT becomes 9. As the time increases, like to when it is close to 330 minutes or 360 minutes, the odds ratio is just 1.22 and the NNT becomes 21. So the slope is not significantly altered by age or stroke severity. So the speed in which we give IV thrombolysis is very important. And also in this, you can see that as the treatment delay, the time to administer IV RTPA increases, the efficacy decreases. So essentially, IV thrombolysis should not be withheld because of advanced age also. Even though there will be mild but disabling deficits, it justifies the treatment of IV RTPA. So we have to see in this slide that the benefit is time dependent and it's no longer significant when the drug is administered more than 4.5 hours after symptom onset. So, but even though there are some recent evidence which suggests that there may be patients with the persistent ischemic penumbra on perfusion imaging, for whom IV RTPA may still be beneficial up to 9 hours after the symptom onset. But till now, the standard of care is we have to administer IV RTPA. The RCTs have proven that it has to be given within 4.5 hours. Once you go beyond that, except in select cases, there is not much use. So what is the latest American Heart Association or the AHA guideline? So if you see the indication for giving IV RTPA, it is number one is diagnosis of ischemic stroke with disabling neurologic deficit, regardless of the severity. And the number two is symptom onset within 4.5 hours. And number three is wake up stroke with DWI and flare mismatch on MRI, and age should be greater than or equal to 18 years. So time is brain quantified actually. So if, as you can see, per stroke we lose around 1.2 billion neurons and 8.3 trillion synapses are lost. If you suffer a stroke, you get older by 36 years. So every second, approximately 32,000 neurons are lost and 230 million synapses are lost. So every second you age by 8.7 hours if you have not opened up the vessel either by thrombolysis or by thrombectomy. So with a stroke, time lost is brain lost. Time is of very vital importance. Main thing is managing the blood pressure in acute ischemic stroke. So if you see the clinical conundrum, there will be an hypertensive response which occurs within 24 hours of acute stroke. So up to 80% of the patients presenting to the ER with acute stroke will have a systolic BP greater than 140 millimeter mercury. So that happens because the auto regulation of the cerebral circulation in the ischemic area is impaired, and it's passively dependent on the mean arterial pressure. So primary cause of this hypertensive response is compression of the regions in the brain that regulate the activity of the autonomic nervous system. So if the patient is having pre-existing hypertension, diabetes, or elevated serum creat, or if there is a Cushing's reflex, all this can exacerbate the hypertension. So there is a U-shaped relationship between the presenting BP and the outcome after ischemic stroke. Both low and high extremes of BP are associated with a poor outcome. For every 10 millimeter of systolic BP below 150 millimeter, the risk of early death is increased by 3.6%, and the risk of late death and dependency is increased by 17.9%. So for every 10 millimeter rise above 150 millimeter, the millimercury, the risk of early death is increased by 3.8. So if you see any patient with ischemic stroke, with the systolic BP ranges between 150 and 160, as you can see in this U curve. So as you can see here, so if it is between 150 and 160 in this range, the death or dependency is decreased. This data is based on the international stroke trial. So now the current recommended goal for blood pressure in acute ischemic strokes for thrombolysis is it should be less than 185/110 before starting IV RTPA, and it has to be less than 180/105 after starting IV RTPA. So this is how it is. As you can see that if the BP is low, less than 150 also, you can see the mortality rate is high. And if it is more than 160 also, you can see the odds ratio is more than 1.5 and the mortality rate is very high. So the best is if the BP is somewhere between 150 and 160 range. So if the AHA guidelines for managing BP during acute ischemic stroke during thrombolysis is if the blood pressure is greater than 185/110 systolic for diastolic mercury, you can give labetalol 10 to 20 mg IV over 1 to 2 minutes, and you may repeat it one time, or you can give nicardipine 5 mg per hour IV. Other agents are hydralazine, enalaprilat, all those things can be used. So if BP is not maintained at or below 185/110 millimeter mercury, you should not administer RTPA. So management of BP during and after RTPA or other acute reperfusion therapy, to maintain BP at or below 180 bar 105 millimeter mercury, what are the things need to be done? You have to monitor BP every 15 minutes for 2 hours from the start of IV RTPA therapy. Then every 30 minutes for 6 hours, and then every hour for 16 hours. So meticulous monitoring of BP is of utmost importance when you give IV thrombolysis with RTPA or Tenecteplase. So if the BP does not get controlled, or if the diastolic BP is more than 140 millimeter, you can consider giving IV sodium nitroprusside. And then we move on to the wake-up strokes. So wake-up stroke is based on when the patient is last known well. Based on that, we define these wake-up strokes. And IV thrombolysis for selected patients with wake-up stroke or stroke of unknown time of onset is right now they're considering based on the wake-up trial. So in which the patients were randomly assigned with unknown time of symptom onset, who had a lesion on MRI diffusion, but not on flare. So these patients were given IV RTPA. So only DWA changes were there, and there were no flare changes. They were divided into 2 control groups. One group was given RTPA and other was placebo. So if you see that even with patients having wake-up stroke, so if you give IV RTPA, based on MR study, the 90-day functional outcome is very good, even though there is a slight high incidence of intracerebral hemorrhage in those patients if you give IV RTPA for wake-up stroke. Next is the main thing, which is the large vessel occlusion, where it can be intervened using our new gadgets. So if you see this large vessel occlusion means most common site is the extracranial ICA. It could be at the level of cervical ICA or a little bit distal, and then followed by M1 segment of the MCA. So up to 42% of the patients in India have large vessel occlusion. If you see the global stroke incidence, it's about 13.7 million. In that, if you see the global LV large vessel occlusion incidence, it's about 1.7 to 4.5 million. So the presence of large vessel occlusion has been associated with a significantly worse outcomes, increasing the chance of death within 6 months by 4.5-fold. The thing is, if you give IV thrombolysis, there are studies which shows that it can recanalize up to 4 millimeter length in clot. Once the clot length goes beyond 4 millimeter, the length of the thrombus, when it goes beyond 4 millimeter, the efficacy of IV RTPA or Tenecteplase decreases rapidly. And so IV thrombolysis seldom recanalizes large vessel occlusion. So if you see, since 2015, endovascular therapy has become the standard of care for acute ischemic stroke due to large vessel occlusion. So it is a very safe and highly effective treatment if done rightly, and its number needed to treat is of 2.6, which is one of the highest for any procedure throughout the medicine. So while doing mechanical thrombectomy, you have to define the outcome. So for that, we have a score which is derived from our cardiology colleagues' myocardial ischemia score, which they call it as TIMI score. Here we have a TC score, which is ETC actually, which is nothing but the extended thrombolysis in cerebral infarction score. Whenever we do a mechanical thrombectomy, this score we try to achieve a TC score of 2C or 3. Initially it was 2B. Now many studies have proven that TC2B, the MRS score, the modified ranking scale score at the end of 3 months is not so good. They are not functionally independent. To achieve functional independence is the goal of doing a mechanical thrombectomy and achieving a good TC score. So to achieve good functional independence, the TC score should be somewhere between 2C and 3. So 0 means no perfusion. Score 1 means there is anti-gate reperfusion past the initial occlusion, but limited distal branch filling with little or slow distal reperfusion. So if you see what does the score 2C means, it's near complete perfusion except slow flow or occlusion in few distal cortical vessels, such that at least 90% of the territory is perfused in the parenchymal phase. So there are different phases, like parenchymal phase is there, which is corresponds to the arterial phase when you are doing the angiogram, and then you have the capillary phase, and then you have the venous phase. So 90% of the territory should be perfused. That is 2C. TC3, which is the best outcome which we can achieve out of a good after a successful mechanical thrombectomy, where there is complete anti-gate reperfusion of the previously occluded target artery ischemic territory with absence of visualized occlusion in all distal branches. So there should be no abnormal vessel cutoff or slowing. It has to appear as a normal angiogram after you do mechanical thrombectomy. So that is what ETC score 3 means. So now moving on to the techniques of mechanical thrombectomy. So there are different ways of doing this. One, you can use something called as a Stent-retriever. It can be used alone. And then you have something called as an adapt technique, which is direct aspiration technique without the use of a Stent-retriever, using something called as a distal access catheter. And then you have a combined technique, which we call it as the Penumbra technique, where we use the Stent-retriever as well as the distal access catheter. Both are used in conjunction with each other. And then you have other modifications like this badass technique, which I'll just briefly discuss. So what is this Stent-retriever? The Stent-retriever is nothing but a mesh-like thing, as you can see in this picture. It is like a mesh net, which is used to retrieve the clot. So what you are seeing in this picture is from a manufacturer called Stryker, and the product here is called as a Trevo Stent-retriever. So there are various vendors there are modifications of this design. So it is mainly made up of nitinol. This is made up of nitinol, and then this will be loaded into a micro catheter, and then you have to take this device beyond the lesion. Actually, this device has to be taken beyond the clot. At least 2/3 of this mesh has to be beyond. For example, say you have a occlusion in the M1 blood vessel, proximal part of the M1, the vessel is occluded. Then you have to take this up. This device has to go into the MCA bifurcation into the superior or inferior, whichever is the large vessel. So till that extent, you have to take it far. That much distally, this device has to taken far, and then only you have to deploy it, so that the clot gets integrated in the proximal 1/3 of this device, and the distal 2/3 remains free. So that when you are retrieving it, if there are some fragments which are escaping, that can be caught, so that distal embolization does not happen. So that is basically Stent-retriever. And then you have something called as a distal access catheter, which was invented as recently like 3 years ago. It was discovered 3 to 4 years back, and then now it has come into the market, and all over the world we use it. In this picture, it's a model, actually flow model, where you can see that this where the arrow is pointing, that is the distal access catheter. So this is the distal access catheter tip is very soft. It is so soft that this catheter will track easily, and it will not damage the vessel endothelium, and you can take it as high up as M1 segment or even up to the M2 segment, depending on the size of the DAC or the distal access catheter, you can take it. And then while doing the mechanical thrombectomy, you will be using something called as balloon guide catheter. So as you can see, this distal tip has a balloon. This balloon can be inflated by giving the contrast, and this will cause flow arrest basically. So this will be kept in the proximal internal carotid artery, and then it will be inflated, so that antegrade flow doesn't happen. So the clot fragments doesn't get distally embolized, and this offers the best protection. And then you can apply the suction using manually using a syringe or pump or a pump while retrieving the clot which is being entrapped in the stent retriever or the DAC. So this is basically the aspiration pump. This is what we routinely use. This is from the company called Penumbra. So this pump, as you can see, has a tubing, this blue color tubing. It is attached here. It is nothing but a suction pump. It is nothing but a suction pump. So once you switch it on, it will create a negative suction. And one end will be connected here to this tubing canister, and the other end will be connected, as you can see, to your catheter, which is nothing but the distal access catheter end will be connected. So let's see here. This picture, this shows basically a I would say this is called as a M1 cum T occlusion. The clot, as you can see, it is here. And then what you are seeing down is the balloon guide catheter, which has been placed in the cervical ICA. So now what happens? The gray color is the balloon guide catheter. And then inside the balloon guide catheter, you can see a green color tube, which is called as the distal access catheter. And inside the distal access catheter, you can see a black color thing, which is the microcatheter, inside which this stent retriever, the mesh kind of thing, is taken. And then you start deploying. So since 3 devices are used, you call this as a triaxial system. And these devices are connected to the pressure lines, which has normal saline flowing, so that heparinized saline will always flow in these devices, so that thrombus doesn't get formed. So what happens is, as you can see here, this catheter, as you can see my arrow, I'll show the pointer. Yeah. Okay, here, as you can see here. So as I said before, this device, the stent retriever, the mesh, it is taken all the way into the inferior division here, into the inferior M2 division, but the clot you can see is in the proximal part of the M1 segment. It's called, it is a typically, we call this as a T occlusion. So the ACA part is also getting occluded. This is the T junction of the carotid artery. So this part is getting occluded. Now, how do you deploy this? You pull back this catheter slowly. This microcatheter is pulled back. So as you pull it back, this stent gets deployed. It will open up lines. And as it gets opened up, as you can see, the clot gets entrapped into this stent retriever. So once this is done, initial technique, the stent retriever alone technique, what you do now is, now you apply, now you have to inflate the balloon guide catheter here, that is inflated. And then you have to connect this balloon guide catheter to the suction apparatus, or you can use a syringe to apply suction, negative suction, and then pull this stent retriever slowly into the DAC, into the balloon guide catheter. And then you can get the clot out. This is one way. And the second way is, here you can see that this is a Solumbra technique, where this blue color thing, the balloon guide catheter, as you can see, it's inflated here. And then, as you can see, this distal access catheter in this image, it's almost taken up into the M1 segment, and it is touching the end of the stent retriever here. So now what you have to do is, you have to apply suction or aspiration at 2 places. One, this distal access catheter has to be aspirated. Here, second is at the balloon guide catheter level. So both the places you apply full aspiration, and then you pull this entire assembly into the balloon guide catheter and pull it out. So the main thing is the applying of the aspiration at 2 places is very important, so that this clot does not unflow arrest using balloon guide catheter. So we have 3 safety checks. One is balloon guide catheter inflation, so that the antegrade flow does not happen. And then you are applying suction at the level of this guide catheter, as well as at the level of this distal access catheter. So 2 places you are applying suction, and then you are retrieving the stent retriever. And the DAC as a unit, both these things, this mesh and this catheter. Together you are pulling down so that it reaches the balloon guide catheter. With both negative suction at aspiration happening at two junctions, the risk of this clot migrating distally is less. So that's what it is. And then if you see the protocols for acute stroke, you have various institutions use various protocol. So in this figure, initially you can see that as soon as the patient comes, you do a CT scan. If there is no bleed, the CT scan appears normal, the aspect score is good, you initiate IV-RTP therapy, and then simultaneously when the patient is getting IV-RTPA, you can do a CT angiogram, and then so there is no time delay. If you see that, ideally the time for qualifying scan to groin puncture in candidates for endovascular therapy should be, that means we call it as the door to puncture time, the time in which the patient reaches your hospital ER door and the time you shift the patient to the cath lab and you do the groin puncture, that time should be less than 60 minutes. So you do that, and then in cases, for example, wake up stroke, when you don't know, when the patient comes beyond the 6-hour window period, in that time you can do a CT perfusion imaging to quantify the penumbra. And then if there is, the ischemic core is small and the penumbra or the salvageable brain tissue is large on either CT or MR perfusion, then you can take up the patient for thrombectomy. So in this case, they have shown the pre-intervention DSA, which is a left M1 MCA occlusion, and then they've done the thrombectomy, and then they have achieved a good reperfusion. So what the stroke protocol which I use at my hospital is, usually if the patient comes in the window period, I do first a CT brain, stroke window is done immediately, and afterwards my neurologist is intimated and the entire team gets alerted, and then Iv-thrombolysis is initiated by him based on the CT findings. And then here what we do is, usually we do a MR brain with TOF angio. So in the MR brain with TOF angio itself, we can see whether it's recanalized or no large vessel occlusion is there. Then we shift the patient to the stroke ICU, and then we do a meticulous BP monitoring since we have thrombolized the patient. But if there is large vessel occlusion on MRI with TOF time of flight angio, we can see if there is a large vessel occlusion, then we shift the patient for MT, and then after MT we shift the patient back to the stroke ICU where the BP monitoring is done meticulously. Usually we do the MT under the sedation. There are centers where they do mechanical thrombectomy under GA also. It depends on the availability of the anesthetist. Most of the institutes, if you have a 24-hour anesthesia backup, then I think doing MT under GA is better, because the patient won't be moving, and you have a good stable patient to take a devices. It is easy then. Again, then if you give GA, you lose valuable time. You lose around 15 minutes if you are planning for a GA. So all these things have to be taken into control. So who are the candidates for acute endovascular stroke therapy? He has to be age greater than or equal to 18 years. And the NIHS stroke scale score should be more than 6. And the time from symptom onset to groin puncture should be less than 6 hours. It can be up to 24 hours if evidence of sizable ischemic penumbra is seen on perfusion imaging. That's what the new trials have said. And then he should have a good pre-stroke functional status. And the aspect CT score should be greater than or equal to 6 on the baseline CT scan. This is very important. So if the aspects is like say 3, 4, then the chance of reperfusion injury bleed is very high. So higher the aspects, better the outcome post mechanical thrombectomy, as well as you should have a presence of proximal intracranial artery occlusion. So these trials, all this Mr. Clean, Escape, Extend IA, Swift Prime, these Revast, THRAS, all these trials were called as the happy trials, and most of these trials were published around 2015-16, and the main thing is all these trials showed that they have shown class 1 level A evidence that mechanical thrombectomy is the standard of care for acute ischemic stroke due to large vessel occlusion in the anterior circulation. So as I said before, the number needed to treat with endovascular thrombectomy to reduce disability by at least one level on the MRS scale for one patient is 2.6, which is a very good number actually. So NNT 2.6, only very few disease you can achieve the NNT of 2.6. And then recently you have the Dawn and Diffuse 3. So where the diffusion weighted or CT perfusion assessment with the clinical mismatch in the triage of wake up and late presenting strokes undergoing neuro intervention was made. And based on these two trials, the window period, if there is a mismatch, then based on perfusion imaging, then up to 24 hours, we can take up the patient for mechanical thrombectomy in anterior circulation. And then you have something called as tandem occlusion. So in this case, what happens, there is a cervical internal carotid artery high-grade stenosis or occlusion along with ipsilateral intracranial occlusion. So this tandem occlusion accounts for about 10 to 15% of all large vessel occlusion. And what some studies have shown is if you are doing an emergent carotid artery stenting, if you see a tandem occlusion, do a carotid stenting and then do a mechanical thrombectomy. It seems to be associated with the good functional outcomes than in patients in whom no stenting was done, even though there was a tandem occlusion. There is always a risk of intracerebral hemorrhage if you're doing stenting because of the use of antiplatelets. And then you have something called as the distal medium vessel occlusion, and there which includes the strokes which happen. This incidence is very less, which because of the strokes occurring in the ACA territory or M2, M3, M4 segments of the MCA, PCA, or posterior inferior cerebral artery, anterior inferior cerebral artery, or superior cerebral artery. So any clot occurring here, any stroke occurring in this territory, we call them as the distal or medium vessel occlusion. So there are many studies which are coming up now, which shows that thrombectomy can be attempted in these vessels, but there are no proven RCTs to substantiate this, because these vessels, if you see the anterior cerebral artery or the PCA, they are very tortuous, and these devices are pretty large, and to take these devices like Stentretrivers into the pica or M4 segment, there is always a risk of injury to the vessel. So still there are no class 1 or level A evidence to support distal medium vessel occlusion mechanical thrombectomy for these vessels. And then you have your posterior circulation stroke. So actually we tried to emulate whatever is happening in anterior circulation stroke. We tried to cut, copy, paste and do it for the posterior circulation stroke, which essentially comprises of either your vertebral artery segment V4, P3 segment occlusion or a basilar artery occlusion. So despite the advances in endovascular treatment and its success in recent RCTs, if you try to recanalize posterior circulation large vessel occlusion, the incidence of futile recanalization and mortality is still high. So why that happens, because the underlying pathology is the success of the endovascular therapy for posterior circulation is largely determined by the underlying pathology. For example, if there is a tight basilar artery stenosis and the plaque there ruptures and it occludes the vessel, you do a thrombectomy and you can remove the clot, but then because of the high stenosis there, because of the pre-existing intracranial atherosclerotic disease there, the vessel will be occluded again. So you do one attempt, two attempt, but then in spite, momentarily there will be opening of the basilar artery, but again it will get occluded. unless you put a stent there. But to take all these decisions, to deploy a stent emergently there, you should have the correct stent, correct size. All these things matters. That's why the outcome in posterior circulation is largely influenced by the etiology. So if you want to increase the efficacy of endovascular treatment for posterior circulation stroke, the technical strategy should be tailored to the presumed etiology. So, but still, there are certain studies which says that up to 8 hours, you can open up a patient with basilar artery occlusion. But as far as my experience is concerned, with my experience in this part of Tamil Nadu, posterior circulation stroke still remains an enigma, and to give a successful outcome is pretty difficult, and there is no defined class A level 1 evidence in the use of mechanical thrombectomy for posterior circulation stroke. What they say is, if you achieve removing of the clot, for example, in the basilar artery, if you put your device there, Stentretriever or the suction using distal access catheter, if you remove the clot in one go, the first attempt itself, what we call it as first pass in endovascular regime, if you achieve that, then the outcome is good. That's what they have found out. Still, it is not very clear whether you have to do mechanical thrombectomy for posterior circulation stroke or not. So, in acute ischemic stroke, vast number of neurons, synapses, and nerve fibers are irretrievably lost every moment in which the treatment does not occur. So, it is a highly treatable medical emergency where every second counts. So, let's see a case scenario now. So, this is Mrs. S, a 32-year-old female lecturer in a local engineering college. So, she develops weakness of left upper and lower limb, 1.5 hours duration. So, if you see the history of presenting illness, she got up at 6 a.m. She was making coffee around 7 a.m. She suddenly dropped the cup and she fell on the floor. So, she came to our ER at around 8:30 a.m. So, the last seen normal was at 7 a.m. So, it is approximately 1.5 hours she came. So, the diagnosis of acute stroke was made. The neurologist examined. The vitals were checked. This was her pulse. BP was slightly high. So, on examination, there was dysarthria and left human facial palsy was there. Power in the left upper limb and lower limb was 0, and the NIHS score was 8. With the permission, I am just playing this video. As you can see that
சொல்லுங்க ஈ கண்ணை இறுக்கி மூடுங்க. 2 கை தூக்குங்க பார்க்கலாம். 2 கையும். அது வரலையா? அது வரலைங்க கை கால்.
So this was the thing. So CT brain was done. Aspects was 10. Nothing major. So for this patient, our a neurologist, he initiated the Iv-thrombolysis. So Alteplase was given. So I think we gave around 55 mg of Alteplase. Patient was shifted to MRI post Alteplase. The MRI diffusion was also not showing any major lesions that time. But if you see the MRA, you can see that the right M1 is cut off. There is no flow in the right MCA territory. You can see the ACA on the left MCA is filling normally. So it is a large vessel occlusion. We explained the family, and then we decided to do the mechanical thrombectomy. The family members gave consent. As you can see, the DSA run here. This is the right internal carotid artery, uterus part, cavernous part. This is the right A1, and this is the left M1, and you can see that it is cut here. Don't see any flow here. So what I used here was the badass technique, where a balloon guide catheter with large bore distal access catheter and a dual aspiration was done using a Stent-retriever. This I explained in the previous sketch before. That's what I did. So with the first pass itself, I was able to fully open up all the vessels, and nice flow was seen distally. There was no abrupt vessel cutoff or contrast stagnation, and TC3 score was achieved. So this clot was kind of white thrombus actually. There are two types of thrombus. If the RBC is rich, we call it as red thrombus. If it is fibrin rich, then we call it as white thrombus. So when I did the final check angio, you can see that complete perfusion is happening without any delay in any phase, in the arterial phase as well as capillary phase and venous phase. You can see that there is no delay and complete perfusion was achieved. So this is the same patient few hours after thrombectomy in the ICU.
நான் லெஃப்ட் சைடு நல்லா என்ன தூக்க முடியுங்களா? வலிக்குதுங்களா? சரி ஓகே. கால் அப்படியே மடக்கு. லெஃப்ட் கால். ஓகே. ரைட் சைடு கொஞ்சம் அசைங்க, லைட்டா அசைங்க மட்டும் போதும். ரைட். Just லைட்டா மூவ் பண்ணுங்க.
Groin sheath and then compression was there. We asked her not to move her right lower limb much. So we did a workup for her, and we found that because it was a young stroke, she was in her 30s. So the workup for young stroke was made, and we found that the protein S was deficient in this patient. So if you see that the important take-home message here is Iv-thrombolysis seldom recanalizes large vessel occlusion because of large clot burden there, leading to death or disability. And large vessel occlusion comprises 24 to 38% of acute ischemic strokes. And landmark trials have established the effectiveness of mechanical thrombectomy over best medical treatment with the NNT of 2.6. And mechanical thrombectomy is effective up to 24 hours after acute ischemic stroke due to large vessel occlusion, with salvageable brain demonstrated on perfusion scan and good collaterals. So thrombolysis should not be withheld because of advanced age, mild but disabling deficits. So benefit is time dependent. So the golden period is 0 to 4.5 hours for thrombolysis. And the first 90 minutes after symptom onset is very important. As you see, the NNT is only 3.6. And when it comes to 3 to 4.5 hours, if we give the RTPA, the NNT increases to 5.9. So mechanical thrombectomy is the standard of care for large vessel occlusion in anterior circulation ischemic stroke with the NNT of 2.6. So 1 in 4 of us will have a stroke. Don't be the one. Thank you very much. So I would like to thank once again the TANS organizing team for giving me this opportunity to talk on this important and common topic on the occasion of World Stroke Day. Thank you, sir. The floor is now open to discussion.
Thank you, Dr. Goutham, sir.
Thank you, sir.
Now we will have the panel discussion. So first we will have we have 5 questions from Dr. Goutham's talk, and now we will put the first question, and then we will continue our discussions. So first question is first. Naveen, first question.
One second, sir. I'm keep on muting, sir. Someone is. Sir, yes, sir. Last. Sir, Rajesh Babu, sir.
Question number 1. How many aspects of stroke symptoms are listed on the NIHS stroke scale? How many aspects of stroke symptoms are listed on the NIH? So you can start answering questions. Okay, now I invite our panelists, Dr. Anand Sanmuraj sir, Dr. T.C.R. Ramakrishna sir, and then Arul Ramraj sir. First, I request Dr. T.C. Ramakrishna sir to give his view about the management of the stroke.
Sir, am I audible, sir?
Yes, sir, audible, sir.
Sir, thank you, sir. Thanks for the invite. I think Goutham has spoken extensively and he has covered almost every aspect of acute management of stroke. So probably what I would do is, what are the things? One, about the prevention, because the theme for this year's stroke is together we are greater than stroke. That means the idea is mainly prevention. So that's one thing probably I will focus on, and some other aspects which probably Goutham has not touched upon because focus is on acute ischemic stroke management. One thing is, we all know about the risk factors. So risk factors, generally we say it's modifiable risk factors and non-modifiable risk factors. The modifiable ones are diabetes, hypertension, dyslipidemia, and lifestyle. Non-modifiable are age, sex, genetic factors. So whatever modifiable, we have to keep them under control. Now the guidelines is, we all know, for example, LDL level, we should keep it less than 70. And for some of the studies, it should be kept less than 55 milligram per DL of LDL. So that, like that, when blood sugar, HbA1c, we should always keep it less than.
Speaker, sir, kindly unmute yourself and speak, sir.
Okay. Am I audible now?
Yes, sir.
Yes. So blood pressure should be kept less than 130 by 80 millimeters of mercury. If it is less than 60 years and more than 60 years, we should keep it less than 140/90. So one thing we should try to focus to prevent strokes. Once stroke occurs, main focus should be on acute management of stroke. The one thing I don't know the participants, mainly we have to keep an eye on blood pressure. For example, if we are not lowering the blood pressure and we are thrombolizing the patient, that is one major risk factor for the patient to develop hemorrhage following thrombolysis. Similarly, we should not be giving a loading dose, or we should not be giving a heparin or low molecular weight heparin, or we should not be giving nifedipine sublingual, which is being commonly done before actually knowing what is the reason for stroke. Because if we have given it, even though a prophylactic dose of low molecular heparin is not a contraindication for thrombolysis, but it creates some doubt in the minds of the people who is going to thrombolyze them. Similarly, if you are going to give nifedipine sublingual and lower the BP much, for example, if the BP from 180 to it goes down to 110, then there it will cause worsening of stroke. So we all know that the blood once stroke occurs, the blood flow to the brain is dependent on not dependent on the blood, or the autoregulation is lost. So it is mainly dependent on the blood pressure. So if you are going to reduce the blood pressure to a large extent, then the stroke will worsen. So we should be careful on that. And the other thing is, for example, if somebody has got a large vessel occlusion and more than 60 years, we don't have any significant comorbidities, or even if they have diabetes or hypertension and under good control, we should always consider atrial fibrillation as one of the etiologies, because in them the treatment is going to be different. Our antiplatelets may not work in them and we have to give them anticoagulant. Similarly, even if we found AF patients, even if they don't have a stroke or if they don't have TIAs, we have to start them on anticoagulation, because that is better than using antiplatelets in prevention of strokes. So, each year there is a theme for World Stroke Day. One of there it was women also will get stroke. The general idea is that women will not get strokes, and only men are more likely to get strokes. But there is some difference in that women are more likely to get strokes, or not more likely. Women also will get strokes, and if women get, the chances outcome is much worse when compared to males who get strokes. So these things I thought I will focus upon, and if there are any questions, I will be happy to answer. Hello, sir.
Yes, sir. Thank you, sir.
Rajesh Babu, sir.
Yes, sir. Now I request Dr. Anand Sanmuraj sir and Arul Ramraj sir also to give their views about the stroke.
First of all, I thanks association and members. Regarding this neurosurgeon's point of view, we are mainly treating the hemorrhagic stroke, but our management in ischemic stroke is mainly with the decompressive craniectomy, in terms if the edema is so severe and compressing the normal brain. Now, with the, and another thing is for a reperfusion causing hematoma, where we are doing a decompressive craniectomy. But with the invent of mechanical thrombectomy, our neurosurgery colleagues are and ourselves are doing a lot of mechanical thrombectomy cases too. Since we are having a biplane cath lab, we are doing mechanical thrombectomy with our colleagues. So, good thing is, we can, in these cases, recovery is so good, one thing. And very important thing in our government setup hospital is the time to reach the hospital is delayed. The golden hour of 4.5 hours is delayed, one thing. Another thing is after reaching the hospital, that is what Dr. Goutham has nicely presented, is the door to puncture time. It also gets delayed due to because of some communication gap and routine protocol and all. So that we are sorting out, because initially the patients will be admitted in the neurology side. Once they look after the cases, the information has to be passed to the neurosurgery. Then radiology also has to be organized. So there's some delay. To reduce this time delay, now the artificial intelligence is helping, but not in our hospital, in other hospitals, some private hospitals, in the higher centers also, they are having app. Some example is a rapid AI app where the information, once the patient is entering the hospital, sent for a CT scan, the information of any infarct is passed, that the images has been transmitted to all the stroke team, all radiologists, neurologists, and neurosurgeons on immediately, and they can have the report. Any CT angio as well as diffusion weighted MR images can be taken immediately, and aspect score also can be calculated. So the plan for a mechanical thrombectomy is planned so early. So this is very nice invention for the stroke management, for reducing the time of intervention. And Goutam's presentation is very wonderful, and I had certain questions for him to ask also. Shall I ask now, sir? Goutham, whether
Yes, sir.
MRI is mandatory for this mechanical stroke management? You feel like that?
No, sir. MRI definitely is not mandatory, sir, for stroke. Actually, if you have a now what they are saying is, if you know the time of onset correctly, in many places they just do a plain CT. And if you see the CT aspect score and it is good above 6, you don't have to do any other investigations. If you know the time correctly, the time of onset correctly, you push the patient directly to cath lab. That's all. You don't have to waste time. And of course, clinical examination, the NIHS score also have to be high. So while doing the CT itself, if you can do a CT angio of the brain and neck vessels, it will make your job easier. It will take additional 5 minutes extra.
Exactly.
We get a very good information in that, so that we can confirm that there is a large vessel occlusion, as well as you can have an idea about the neck vessels and the arch, how difficult it is going to be placing your devices and everything. And you can plan your treatment in 5 minutes. So that is what I would say, sir.
What is your door to puncture time, Goutham, in your setup?
Sir, to be honest, it takes roughly about 1 to 1.5 hours. It takes, sir, at least. Because the main problem in our private setup is explaining the financial issues to the patient. So they expect, if they are spending, definitely this is an expensive procedure. You cannot do without, at least it will cost you around 2 to 3 lakhs for doing a mechanical thrombectomy. So what they ask is the outcome. Will the patient walk after thrombectomy? That will be the question. So to convince them, to explain how much is going to be the success percentage, it takes half an hour. So it takes a lot of time. But if the patient is young, then it's easier to convince. In young strokes, of course, he is young and people don't think twice to spend the money, so they immediately agree. But if he is a senior person, then they take some time, they ask someone. So we lose the very valuable time in convincing the patient. So it takes roughly about 1.5 hours, sir.
What about IV thrombolysis? You give immediate after the thrombolysis only, you will be shifting to mechanical thrombectomy, I think so.
Sir, in our hospital, the thrombolysis is started irrespective whether it's a large vessel occlusion or a small vessel occlusion. Thrombolysis is, once you do the CT, clinical assessment, and you do the basic non-contrast CT, based on that, if it is time window is there, then you give the IV thrombolysis is given with Tenecteplase. That's what we use in our hospital. Alteplase they don't use. Our neurologist uses Tenecteplase here.
Sir, now we will have the second question, sir.
Yes, sir.
Thank you. After that, we will continue the discussions. The second question will be, adagrasib is used as a reversal agent for Okay, we will continue the discussion, sir. There are two questions in the audience. Now I request our Dr. Arul Ramraj, sir, to give his views from the radiologist point of view. What is his plan of action? How is referred, how he is following up the patients? Arul Ramraj, sir?
Yes, sir. Thank you, sir. Am I audible, sir?
Yes, sir.
Yes, sir. Okay, sir. First, I thank you for calling me to this panel discussion, sir. Actually, this topic which is covered by Dr. Goutham is very good, and I will just touch upon what are the protocol which is done in our hospital. We in our hospital do an MRI-based imaging for acute stroke protocol. This is because we have 2 units in which two MRI units are there. So at any case, any time of emergency, one can be allotted for that. So there will be no delay when compared to CT or MRI. But there are a lot of debate when you have only 1 unit, or CT is more available than MRI. And the expertise needed for CT is also less. So in most of the centers, in the remote places, CT will be the preferred mode of imaging for acute stroke imaging. But in higher centers like us, where we have 2 units, where one can be dedicated for acute stroke imaging, we will usually follow a MRI based acute stroke imaging. And in MRI acute stroke protocol, we do only 4 sequences, which will be over in approximately 8 minutes. We will do a diffusion weighted image. We will do a susceptible weighted image. Diffusion weighted image will show the infarct or susceptible weighted image will show presence of hemorrhage and presence of thrombus within the vessel. If there is a large vessel occlusion, we will see the thrombus and we can see the length of the thrombus, and we will see it will also show any presence of any microbleed, because most of this patient will be hypertensive or diabetic, and if the presence of microbleed more than 10 or 12 or multiple microbleeds, it is a contraindication for thrombolysis. Then if you can show the microbleeds, then the flare sequence which will show in the wake up stroke like that. If it is diffusion flare mismatch, then the time of ischemic insult should be less than 4.5 hours. Then some collaterals. CT and CT perfusion, CT angiogram is better if you do a multiphasic CT angiogram. That is, first run we will cover from the aortic arch to the vertex. Second and third runs you will cover only the skull within the brain only. So in the third run you can see the collaterals. So there are a lot of grading system of how to visualize the collaterals. But by visually, if you see the collaterals and compare with the opposite side, if the collateral circulation is good, then that person is a good candidate for endovascular thrombectomy. In case of MRI, the flare images can show slow flow within the collateral vessels. So the MRI can also show, but it is relatively less sensitive when compared to CT perfusion, CT angiogram. MR angiogram of the neck and brain can also show large vessel occlusion and tandem stenosis. Can also diagnose tandem stenosis. When coming to the perfusion studies, actually the perfusion studies, we are not doing perfusion studies routinely in our hospital. We are doing arteriospin labeling, which is a non-invasive perfusion study. The non-invasive perfusion study will show only the CBF, that is the cerebral blood flow. And if the cerebral blood flow is decreased, and we will compare this with the diffusion weighted image. If the diffusion weighted hyperintensity is small and the CBF is large, then we will consider it as a case of ischemic penumbra. So routinely we will do MRI brain stroke protocol with these 4 sequences. And if there is large vessel occlusion only, then we will proceed with the ASL. Otherwise, we won't do ASL as well. Any other questions, sir?
Do you have any pictures to show, sir? No.
No, I have a few basic imaging appearances, but I don't. If you want, I can show that.
There's a question in the chat box. In primary care setting, what first aid can be given before referring to a neurologist? In a primary care setting, what first aid can be given before referring to a neurologist?
Sir, shall I answer, sir?
Yes, sir, please.
Sir, actually, first aid, no first aid is specifically there, sir, because even though we have read in our textbooks, this ischemic stroke will have such a finding, hemorrhagic stroke will have such a finding. Clinically, it is very difficult to differentiate an ischemic stroke from a hemorrhagic stroke without doing a CT, sir. So no first aid. You have to shift the patient for imaging at the earliest. If the scan doesn't show hemorrhage, then probably we have to consider thrombolysis. So that's what I try to say, sir, that we should not give any low molecular heparin. We should not give any loading dose. We should not try to reduce the BP drastically. Before we should refer the patient, or we should send the patient for CT immediately.
Okay, sir. That is a nice message. Thank you for your message, sir. Now, Dr. Arul Ramraj, sir, you
Yes,
can
sir.
tell.
Yes, sir. I will first show some normal. I will show the imaging findings of infarct, sir. This is a plain CT in which we are able to see a hypertense MCA. See this hypertense MCA, which is the thrombosed right MCA. It is called hypertense MCA. Okay, it is one of the signs of acute stroke. Other is this is the obliteration of the obscuration of the lentiform nucleus. See the lentiform nucleus, which is seen on the contralateral side, is not seen here. It is one of the sign of the acute stroke on CT. Then there is a loss of insular ribbon sign. See this corticomedullary differentiation in the insula is lost here, and this can be well appreciated in the stroke window. When you compare with this case, with these images with the stroke window, it will be well appreciated. Then similar to that, there is hypodensity with loss of gray matter white matter differentiation and obliteration of the cerebral sulci. And if you see the contrast study, you will be able to see the occlusion. This is what a wake-up stroke is. This is the MRI. This is the diffusion weighted image. This is the ADC. There is some area of restricted diffusion in the left coronary radiata, which is showing low ADC values. And on flare images, there is no hyperintensity. So there is a diffusion weighted and flare mismatch. So hence, this is an hyperacute infarct. The infarct time should be less than 4.5 hours. And as we see here, this is the collaterals here. See this collaterals here, which will appear here in the sulcal spaces. We are able to see the collateral vessels, which are hyperintense. These are not seen on the contralateral side. This is the SWA image, which is showing the thrombus in the distal M1 segment. And see the MRA image, which is showing the occlusion here. This is the perfusion scan. And what I am speaking about this is a SWA image. This is a susceptible weighted image. In susceptible weighted image also, we can able to make out ischemic penumbra to some extent, because if the blood flow to the right MCA territory, see there is a right MCA territory occlusion here, and the infarct is seen here, and if you see the rest of the area of MCA territory, it is showing dilated veins. These veins are dilated, appearing dilated because due to the deoxyhemoglobin within the veins here. So when there is a diffusion weighted image, SWA mismatch, we can also call it as an ischemic penumbra. Ischemic penumbra. Similarly, this is another case with right MCA territory infarct showing the diffusion weighted diffusion SWA mismatch showing ischemic penumbra. This is what I am mentioning. This is the ASL. This is the ASL, which is the arteriospinal labyrinth. This is a non-contrast perfusion. Non-contrast perfusion, which we will be able to see only the CBF. CBF only is seen. Here there is a right MCA territory infarct. Right MCA territory large vessel occlusion. See, there is a small foci of restricted diffusion here. And if you see the ASL, the large area of MCA territory is showing in hypoperfusion. So it is a case of ischemic penumbra. The MRI can also find out other causes of acute ischemic stroke. And I don't think we will stop with this. Any other questions, sir? I am ready to answer.
Now we will go for the third question. Naveen, which imaging technique is indicated to quantify the zone of ischemia? A. Non-contrast CT with the classification system. B. CT angiogram. 3. Conventional MRI. C. D. Contrast MRI. How many advised chemical or mechanical thrombectomy advised patients went against medical advice and later found to have spontaneous recovery? That was one question from Dr. Yelago. How many advised chemical or mechanical thrombectomy advised patients went against medical advice and later found to have spontaneous recovery? Any experience? That's what they are asking. You can answer, sir. The panelists can answer. Yes, sir. Goutham, sir.
Sir, yeah, I mean, see, sometimes the lacunar strokes, if they have, say, the small infarct in the internal capsule or something, so they will have immediately, I am talking about, say, perforator stroke. So they will have a sudden weakness will be there, but as they said, over a period of 2 or 3 months time, those patients, they do improve spontaneously. So it can happen in perforator stroke where the patient will present with hemiparesis or something, and then spontaneously they do improve over a period of time. But not in large vessel occlusion. Where there is a documented large vessel occlusion, obviously there will be infarct, and then they will have a residual weakness. They cannot have a full functional recovery if not intervened. So these cases rarely do happen.
Okay.
So
Thank you, sir.
actually, the MRI based imaging system scores over CT in that aspect only. In
Yes,
case of
definitely.
TIA and lacunar infarcts with low large vessel occlusion, if the infarct size is very small, very tiny, or if there is a case of TIA, then MRI imaging is more appropriate in that setting for CT.
Yes, sir, I definitely agree, sir. In fact, I would suggest that MRI actually gives larger information than CT.
Yes.
It gives more, I mean, we can be able to tell the prognosis also to an extent
Yes.
based on MRI to the family, actually. So, MRI gives us much larger information than CT, definitely. We have to agree that. I think if your center has the capability, I think MRI should be the first option. If you don't have MRI, then I think we can think about CT. Yeah.
There is one more question. Is it mandatory to give anti-epileptics in a clinically diagnosed stroke at primary or secondary care level, sir?
TCR, sir.
TCR, sir. Is it mandatory to give anti-epileptics in a clinically diagnosed stroke at primary or secondary care level? Sir?
Hello.
Yes, sir.
Sorry, sir. I didn't. Question.
Is
Please
it
tell me
mandatory?
again.
Is it mandatory to give anti-epileptics in a clinically diagnosed stroke at primary or secondary care level, sir?
No, sir. No. The recommendation say we should not give anti-epileptics prophylactically, sir. It doesn't have any role. If by giving prophylactic anticonvulsant, we are not going to prevent future occurrence of epilepsy also. So prophylactically, there is no role to give anti-epileptics, sir, either primary, secondary, or tertiary level.
Okay, sir. Thank you. So another question is, what will be the antihypertensive drug of choice in the primary care level?
Sir, in case of acute stroke, if you are not going to thrombolize, we should give drug only if the BP is more than 220 by 120, sir, as per the guidelines. If we are going to thrombolize, we should give anti-hypertensives only if the BP is more than 180 by 100. If the BP is less than, for example, the BP is around 160, 90 or 170, 100, we need not give antihypertensives in the acute setting because this rise in BP could be secondary. So unless he is a known hypertensive, if he has got secondary or end organ damage due to hypertension, we have to start them on medications. Otherwise, we can wait in the first 2 weeks before starting them on antihypertensives. And the drug for antihypertensives is as usual, sir. Either we can give AC inhibitors, angiotensin receptor blockers, or calcium channel blockers. But one important thing is we need not start medications in the acute phase. If they are already known hypertensive and continuing, if they are on medications, we can continue the antihypertensives. That too, there is a lot of controversy in that. If the BP is 130, 80 or 120, 80, we need not continue them. If the BP is on the higher side, we can continue. We need not start antihypertensives newly in the acute phase.
Okay, sir. Thank you. Now we will go to the fourth question. Naveen. Which is the most accurate regarding ischemic stroke management? Mechanical thrombectomy is contraindicated in patients receiving fibrinolytic therapy. Routine prophylactic use of anti-epileptic drugs is recommended. Cardiac monitoring for arrhythmias such as AAF is recommended. Which is the correct answer of the 4?
Question, sir. I'm a general practitioner. This is the
Yes,
first
sir. Come on.
golden hour, 4.5 hours. Our professional has said no treatment is required. But any reassurance to the patient? My question may be dicey, but any reassurance can be given to the patient, sir, because there is no medication is required. That's what the opinion we have got. Is there any reassuring treatment we can do?
Sir, sorry, I didn't get your question, sir.
First to 4.5 hours, the golden time.
Yeah.
There is before going for CT and all, we are not clear about the diagnosis at the peripheral setup level.
Correct.
We GP, sir. At that level, if we don't give any treatment, like is there any reassuring treatment we can do, sir? That is a thing. Like any intervention we can do.
Okay. As I think TCR sir was saying, sir, there is no reassurance you can give. If it is a stroke, means you have to do imaging. Imaging is the next thing has to be done, sir. You have to do CT or MRI, whichever is nearer to you, you have to do that.
Thank you, sir.
Dr. Arul Ramraj, sir.
Yes,
So
sir.
immediately in your hospital or any of the any hospital, if we are subjecting the patient to do the radiological evaluation,
Sir.
what investigation they should ask? Only the CT scan is enough or MRI? How they have to ask for it?
Sir, in our
As a
setup,
practitioner, from practitioner's point of view.
okay, sir. Regarding acute stroke imaging,
Yes, sir.
we are following in our hospital. Once the patient comes to the emergency, they will do.
Yes, sir.
They will request for an MRI brain stroke protocol. Okay, our MRI suite is adjacent to the emergency setup. So they will refer the patient there. Immediately, the patient will be taken for stroke protocol. If any other patient is on the scan at that time, we will stop that scan and we will give preference to the stroke imaging. And within 8 to 10 minutes, the scan will be over. And we'll through phone, it will be intimated to the referring emergency physician. Okay, if there is if it is an hemorrhage, then nothing needs to be done. If it is acute ischemic stroke, they will ask only 2 questions. One is if there is flare hyperintensity. Second, if there is any hemorrhage. Third, there is any large vessel occlusion. And all these things will be answered through to the emergency physician immediately. And if it is referred to a particular neurologist, we will call that neurologist and we will inform him as well. If it is less than 4.5 hours, then they will decide on the IVT. There is IVT. And if it is the large vessel occlusion only, then they will decide on the mechanical thrombectomy. So if it comes to our emergency setup, and see the thing is we have even in the night time also we have 2 technicians. So it is easily available. And if any stroke imaging is coming, then we will be also intimated there. One of the postgraduate will be there in the hospital as well, and we will, as consultant who is on night call, will also be intimated. And coming to that rapid AI software, which sir was telling previously, actually we also heard that software, and in that case, if there will be a group which suppose there are 10 members in the stroke unit, now all the members' phone that app will be installed, and once the patient enters the hospital, everybody will be intimated through that app, and you can see the images, and you can see, and you can all the stroke unit members can see the images. They can go through that, but it is quite expensive. It is quite expensive.
So and it's around 40 lakhs. The software is.
Yes, it is quite expensive. And the reason why we are not doing the perfusion studies routinely, there is contrast perfusions. Contrast perfusion is, it will take approximately 10-15 minutes. Okay, after that, and the interpretation is also there. So most of the times it is time consuming. So what we will do is, we will do a diffusion weighted image. If it is positive, then we will do SWI, flare, and MRA. If there is any large occlusion, then we will go for ASL. Otherwise, we will stop with that. And if there are micro lacunar infarcts or micro bleed, say it is a case of hypertensive with hypertensive microangiopathy, small vessel ischemic disease. with a small lacunar infarct, then there is no need for doing an ASL. This is a protocol which we follow in our hospital. And our hospital, this intervention is done by an intervention neurologist, intervention radiologist there. So he will take care of the EVT.
Okay, sir. Nice. Thank you.
Thank you, sir.
So perfusion study is not routinely being done, even
Sir,
for small vessel diseases.
So small vessel diseases, the perfusion study is not going to be useful, sir. Only when there is a large vessel occlusion, perfusion study is needed. There is only.
If you don't know the last well-known time, then it is needed.
Then it is needed.
Yeah.
See, if it is less than 4.5 hours, then they will go for IVT. And if it is after 6 hours, previously the mechanical thrombectomy was suggested within 6 hours. Now it is not like that.
Yes.
The time can be extended if you know the presence of ischemic penumbra. So if the ischemic penumbra is larger, then you can extend the time frame for EVT for up to 24 hours, sometimes more than that as well.
Exactly. If there is tissue, even up to 36 hours, you can do. That's what. Yeah.
So this perfusion is needed only when you are planning for that. So it is seen in a subset of the cases. So in our setup, we will do ASL. ASL is a less time consuming and it is non-invasive. Just like another sequence in the MRI, like a diffusion weighted image or flare image, it will take 2-3 minutes. So in the ASL, will show only the cerebral blood flow, So if there is a hypoperfused area in the cerebral blood flow in the ASL, we will compare with that with the diffusion weighted image. And if there is a mismatch between that, we will take that as an ischemic penumbra. This is.
So which machine do you use for MRI?
Sir, we have a 3 Tesla GE machine and an 1.5 Tesla Siemens. In both that we will do.
Both as the ASL software.
Yes, both as the ASL software. So the ASL was developed long time back, sir.
Yeah. Yes. Yeah.
So it is routinely available. In most of the scanners, it will be routinely available.
The settings will be there. Okay.
Yes.
Yeah. Thank you, sir.
Now we will put the fifth question. What is the role of antiplatelet agent in the management of ischemic stroke? Aspirin therapy is recommended within 24 hours of symptom onset in tandem with RTPA administration. Aspirin therapy is recommended within 48 hours of symptom onset, but should be delayed for at least 24 hours after IV RTPA administration. Aspirin therapy is recommended starting at least hours after symptom onset in patients who do not receive RTPA. Aspirin therapy is now common in patients with ischemic stroke. So I request to ask Dr. Anand Shanmugharaj sir. Now they are established center in most of the medical colleges. People have started doing it. In your center, how you are doing it? How you were able to do your work in your institute, sir? Anand Shanmugharaj sir.
Yes, sir. You are having
in the government setup.
Yes, sir. In government setup, the thing is certain administrative difficulties are there. Otherwise, we are having the biplan cath lab. We had cath lab technicians. Only one technician is available. It needs a 24 hours team technician as well as 24 hours staff nurses. But we are having one. In spite of that, we managed to do cases with the available technician. And we are having 5 neurosurgeons. All are trained in endovascular procedures. Diagnostic procedures routinely we are doing. For a mechanical thrombectomy, our number is limited, sir. Due to the availability of catheters and all, there is some difficulty is there. But anyway, we are doing, government is also supporting us through the CMCHS scheme, sir.
So now, how long you are doing the procedure, sir, in Coimbatore Medical College Hospital?
Sir,
since when it is available?
This mechanical thrombectomy available for the past 1.5 years we are having, sir. But we had some limited numbers only we have did, and we had good results too. But
approximately how many cases, sir?
Recently, we did only 3 cases we did, sir. The problem is availability of catheters and all, sir. There is the cost is very, very high comparing to the government, that is a scheme amount, and this problem is there, but that we have represented to the government also. But in future, if adequate technicians and staffs as well as materials, especially catheters and everything is available, we can do it as a routine, sir.
No, please. Dr. Goutham, sir, you are in Salem.
Yeah,
So, how is that people suddenly getting the stroke-like problems? How they rely on the place like Salem, and whether they are able to continue the treatment there, or they wanted to go to Chennai or Bangalore or Coimbatore. What is your view about that? Because since all the procedures and treatment are getting advanced in each and every place now.
Correct.
So in Salem, what is your view about that?
Okay. Sir, if you
In your
see,
experience.
yeah. In Salem, we have, I attend 2 hospitals, and one is Vinayaka Missions Hospital and another is SKS Hospital. In both the hospitals, we have a monoplane cath lab, and both the cath labs are equipped with all the latest software, including 3D RA, 3D roadmap, and fully it's a neuro endovascular therapy capable cath lab. And I go to one more center in Erode also. So that center is also equipped with it's a monoplane lab, but it's equipped. Now, when patients come to us, acute stroke patients, they do come to us, and all these cath labs are equipped with the Stentretrivers, the balloon guide catheters, and the DAC, and all the gadgets which is needed to treat any large vessel occlusion. So we tell them the cost and the importance of the procedure. They do agree, and we are able to convert. This is more, I would say that hemorrhagic stroke due to aneurysm rupture, that we are able to convert more than acute ischemic stroke, to be honest. So there the time is more to convince the patient, and we are able to explain more, and we get a few more hours. So endovascular therapy for aneurysm is growing more, and ischemic stroke, we are able to convince them, and it's slowly picking up. So it's not that patient do agree. Lot of patients, even the lower middle class patient, when we explain to them that this treatment is needed and this will cost you 2 or 3 lakhs, they do try to arrange the money and they do give consent. I think the trend is changing. They don't say that we have to go to a higher center in a big metro city. So they do accept the standard of treatment which we are offering. So I think the trend is slowly changing, sir. Because this is a hyper acute and the decision has to be made fast, and we explain them that you lose the golden hour by traveling far to metro cities for this treatment. It won't make news. It won't make much of use. Now I think the awareness is slowly picking up. 5-6 years back when I came here, that time it was very hard to convince anyone for any kind of higher end treatment. But now I think the trend is slowly changing, and people are getting treated at tier 3 city like Salem, sir.
Give mannitol and Dexa in the primary care before referring the patient? That was the question.
I think there is no role for mannitol and Dexa in acute ischemic stroke, sir. In the window period.
That's what even before doing any investigations, there is no role in giving any of the drugs, sir. Only after seeing the scan only we can give the drugs, sir. So by giving the Dexa or the mannitol, It is not a mandatory one. That is the main thing, sir. Like our anti-epileptic drugs also. So now I request Naveen to put answers one by one. For the first question, answers for the first question. How many aspects of stroke symptoms are listed on the NIHS stroke scale? It is 11. Is the answer B? Actually, for this question, no one has answered correctly. So there are no winners for this question number 1. So question number 2. Question number 2. Question number 2. Idarucimab is used as a reversible agent for dabigatran is the answer, and this was given by Dr. Jayalakshmi. Which imaging technique is indicated to quantify the zone of ischemia? The answer is A. Non-contrast CT with the classification system is the answer, and the winner is Dr. Raghu. Which is the most accurate ischemic stroke management? Hyperthermia should be avoided. Then the fifth question. What is the role of antiplatelet agents in the management of ischemic stroke? Aspirin therapy is recommended within 48 hours of symptom onset, but should be delayed for at least 24 hours after IV or TPA administration is the answer. And the winner is Pranshu Mehta. Pranshu Mehta is the winner. There is a question in the chat box by Santaram. Is there any role for heparin or fractionated or unfractionated after giving TPA? Dr. Santaram. Sir, answer, sir. Goutham, sir. Do you want to tell anything?
Yeah, fractionated or unfractionated heparin has limited
After
roles.
TPA.
After TPA, as I said, after 48 hours you can give, sir. Should be avoided in the first 24 hours. If you have thrombolysis.
Okay.
Yeah.
Okay, sir. So it was a very nice discussion altogether.